there's a swath of data from the meeting this weekend that I think warrants some discussion points, and you alluded to the PEACE-3 trial, which I think has the potential to impact patients in the metastatic castration-resistant setting. So just as a review, the PEACE-3 trial randomized men with metastatic castration-resistant prostate cancer to receive either enzalutamide as monotherapy or in combination with radium-223. An important point to note is that in this trial, patients must have not received a prior androgen receptor pathway inhibitor, which does not reflect the majority of patients in contemporary practice who do receive that in the castration-sensitive setting. In addition, bone-modifying agents were a necessary element for patients on trial. But as mentioned, the primary endpoint of radiographic progression-free survival was met in this trial. There was a hazard ratio of around 0.69, which was very impressive. And there was also a trend towards overall survival advantage with a very similar hazard ratio. And as stated, the safety profile reported in the study was excellent. Really only the most common thing that was observed was hypertension as a product of the enzalutamide, most likely. So, I'll open it up to the rest of the discussants. How are we approaching this data, and what are our thoughts around it?
The reality is that my impression of radium-223 is it's an agent that came out of one study, an older study that didn't have those hard endpoints that we are looking at now. And it is public knowledge, do not employ this agent as much in the presence now of lutetium PSMA, right? Because that is a direct theranostic. Having said that, looking at this data, I may have done a disservice because there may be, let me not say additive, there may be a synergistic effect, and that's what we want to look at with more detail. And it makes absolute sense. We mentioned during our earlier discussion that there was a trial before that, the ERA 223, where we completely failed to protect our patients from adverse event. So this trial corrected the course, did the right thing, which obviously now we can say is a no-brainer. Hindsight is 20/20. But it shows data that we need to look more carefully at. I understand the dilemma and the nuance of, thankfully, most of our patients receiving upfront any of the available RPs, let me call it that way. But let me give you this hypothesis. If I have a patient coming in the door who has responded for, let's say, 3 years and is now showing some progression, I would be tickled to say, and it's bone-related progression, should I give him add on top or shift to enza and give him the radium-223? This is my take-home message, that I would consider that. And that's, as we say in Greece, putting some water in my wine.
I like that statement quite a bit. Dr. Vaishampayan, what is your take on the data?
Yeah, I mean, I think I was very impressed with the data. Main points for that are that it was a very active comparator. Frontline ARPI is very effective, as we know from PREVAIL studies. And most of the other studies of radiopharmaceuticals, especially, have done in comparison to second NHT, so our standard of care for that matter. I think one of the other main points about this is that the overall survival difference, median survival improvement of 7 months, is very robust and has not been seen that much with any other agent in metastatic CRPC. So that, to me, is a big takeaway from the study results, and that the overall survival is pretty mature because they have adequate follow-up. So 80% of the survival events have occurred already. So this is a very mature study presentation of the PEACE-3 trial, and that definitely resonated with me. Now, meanwhile, the field, of course, moved, as Eleni mentioned, and we use a lot of ARPI up front in the castrate-sensitive setting. So I feel like adding the Xofigo in the second NHT, which is where most of us would likely use this in the mCRPC setting, will still be able to enhance potentially the efficacy and maybe provide that long-term survival benefit. Plus the toxicity, additive toxicity, was really minimal. So that, again, is an attractive option to combine the two in mCRPC today.
Well, that's excellent. And I was alluded to earlier. How do we factor in lutetium-177 Pluvicto in the face of this new data? As stated, radium for many of our practices has fallen out of favor. However, in light of this new data, there may be an additional role. Dr. Schweizer, do you have a thought on that?
Yeah, it's a tough one. I mean, we're still waiting to see, word whether or not the PSMA-4 study that looked at using lutetium pre-chemotherapy is going to actually lead to an approval. But I think, assuming that does happen, you're going to have, these two approaches in the same space, and it's going to be tough to know exactly where to use it. Of course, radium's only going to affect, bone disease by and large. So I think patients who've got any soft tissue disease of consequence, you're going to use lutetium PSMA. But, the patient with bone-only disease, again, you may still consider it. And I'll also say, as far as access is concerned, lutetium PSMA still isn't available everywhere. I'm in Seattle, and so I see a lot of patient referrals from Alaska, and they need to come all the way to Washington State to get lutetium PSMA, whereas I think radium is available up there. It's a little easier to handle. So there's practical considerations here too, but I'm with you. I think that ultimately, lutetium PSMA is a theranostic agent. My general impression is that it's probably a more targeted, effective drug in many settings, but of course there's no comparative data to really support that. This is just sort of my impression from using these drugs. I just want to make one other point, because I don't think it was explicitly stated regarding the Peace 3 study, but it was low toxicity, but the big sort of requirement to achieve that is also giving a bone-modifying agent, because we know from ERA 223 that in patients who get it in the absence of denosumab or Zometa, that those patients are going to have really high rates of fractures. So you 100% need to give it with one of those drugs, otherwise you're likely to have the same level of toxicity.